All right. Good afternoon, everyone. Thank you for coming on today. And in the interest of time, I'm going to try to get started right here at 12 o'clock so we can get through as much information as possible. Um, so my name is Dena Kelly. I am a licensed professional counselor and a board certified behavior analyst. And this presentation today is made possible from a grant that we received from the Society for the Advancement of Behavior Analysis. So the main objectives of this presentation are to, one, disseminate information and create a better understanding around ARFID and pediatric feeding disorder, and to also share benefits of applied behavior analysis intervention for treatment with the pediatric medical community. So I want to start by saying thank you to everyone who submitted questions ahead of time. I really aimed to weave all of those answers into this webinar. But if you find yourself having other questions or I didn't hit on it in the way you were looking for, feel free to put your question in the Q&A section. And if I don't get to it during the presentation, I will happily follow up afterwards. All righty. So people, that are joining this webinar today are coming in with different levels of understanding of feeding disorders. I noticed that some of the registrants work with communities already that have these challenges, while others may not be as familiar with it. So I wanted to start with just the idea of what are they? So when we think about ARFID, it's Avoidant and Restrictive Food Intake Disorder. It is a diagnosable disorder with a DSM code. It's typically seen in school-aged and older children, although it absolutely can be present from infancy for some children, as well as for others, it can actually appear later in life. The biggest takeaway for an ARFID diagnosis and what differentiates it from other eating disorders is that it is not at all associated with body image. So the strong avoidance of food is much more due to the characteristics of the food, a traumatic event that involved food, or generalized anxiety in which it's manifesting as one of its ways in regards to food. But you're not seeing individuals that would qualify for an ARFID diagnosis as avoiding food due to wanting to improve their body image in some way. And then there's pediatric feeding disorders. So there's a lot of families that are struggling with these feeding challenges that may not necessarily qualify for a formal DSM diagnosis. They may not have ARFID, but they could still benefit from feeding therapy. And so there's a lot of things that you might see in your practices that kids are struggling transitioning to new textures. So you have a kiddo that's been drinking a bottle and the parents are talking about them having some issues moving on to regular textured food, or from the pureed baby food over to regular textured food. Moving from parents feeding to the child feeding. Being able to actually chew, orally maneuver the food inside their mouth. Or struggling with some intense mealtime behaviors. And so those are still certainly things that, even if they don't fit the criteria for an ARFID diagnosis, may still benefit from some intervention. So one of the biggest reasons that I was looking forward to doing this presentation is because the prevalence of feeding disorders is actually really high. And so, you guys are often the first stop of a lot of these families that are struggling with feeding challenges. And it's not just neurodivergent children or children on the autism spectrum. Almost 50%, a little bit less than that, of neurotypical children are struggling with a feeding challenge in some capacity, whether they're having that difficulty with transition, struggling to chew, or having more of those intense mealtime behaviors. So what might cause ARFID, or pediatric feeding disorder? So there's a lot of different things that can play a role, right? And I think we're still learning about these disorders and discovering more things as the years go on. But here are the top things that we're noticing right now. So certainly we can see some sensory sensitivities to texture, taste, and smell. That one, while certainly common in ARFID, is really common directly associated with kiddos with an autism diagnosis. And often because you're seeing that autism diagnosis, one of those symptoms is heightened sensory sensitivity. And so we're seeing it really across the board. And one of the ways that it manifests is here with food. You could also have that fear-based avoidance. We've had kids who choke themselves, or even in an environment with another child that chokes, right? I had a child once who was in a daycare, and another child in a different table in a separate area of the classroom actually had a legitimate choking incident. It didn't directly involve that child, but it impacted that child to have a fear of continuing to put food inside their own mouth. Vomiting, certainly, we've all had that experience with the stomach bug where you eat something and then later that night you get sick and you end up throwing up, and then you might go a little while without eating that particular food again. We have some kids who then become susceptible to then just cutting out all food and being terrified about that idea of vomiting again. Underlying medical conditions, and this is one of the big ones. And, as I do professional trainings, especially for people that are directly doing the feeding interventions, that I always highlight that this is really important, that we need to make sure that we're looking at and potentially ruling out any medical conditions that could be causing this avoidance to food. So we might see things like food allergies, GI challenges, things like that, some oral motor deficits, things that really malformations in their mouth that could be impacting that food refusal. And then we also have this environmental factors, right, that might be limiting exposure or skill development around new foods. So sometimes there might be a mom that has fear of their child choking. And so because they have a fear of their child choking, they're not giving them regular textured food because they don't want to be involved in it, right? Or perhaps there's a parent that has a lot of kids and they have a really busy life and they aren't giving that child the opportunity to expand their diet or get exposed to things. They're pretty much just, in the rotation of a few different foods. They're often feeding them and they're not expanding their variety and their repertoire and their skill building around mealtime. And so sometimes over time, when we build those habits, that can actually lead to some difficulty with introduction of new food in the future. So what are some of the risk factors that can lead to that feeding disorder? Certainly early feeding difficulties. When we look at things like prematurity, right? They're already struggling with that sucking and suckle motion that can lead to them potentially needing a tube as a baby. Sometimes that can have them leading or avoiding some of those early learning developmental skills for feeding. And so when they miss that initial gap, it can be harder for them to pick that up as they continue to grow. Other things like reflux and allergies, as we talked about, can certainly lead to some of that as well. ADHD and autism, absolutely. There's a lot of just heightened sensory sensitivity and angst as symptoms for those diagnoses as it is. And so manifesting that within food is really common, as well as anxiety disorder, generalized anxiety disorder. We have kids that just have that anxiousness about their kind of across the board. One of the ways in which that can come into play is with mealtime. All right, so a big part of my presentation is being able to share experiences with different kids that could be presenting like some of the clients that are patients that you guys are seeing within your practices. So this first kiddo is Luca. He is 5 years old, typically developing. His parents had noticed feeding issues right at the beginning. And they were continued to be told that his pickiness was normal and to just wait it out. And unfortunately for him, it did not, he did not just grow out of it. It continued to get more intense. And so we're going to share a video from Luca's mom, but I do want to caveat that these videos were shared in another presentation where my company could actually be mentioned. And so while I wanted to share these videos here today, because they do really capture the parent experience, I do just want to note that when my company name is coming up, that's not the focus. I really want the focus for this presentation to be on this mom's experience. So let me see if we could just get this going. Ooh.
My name is Caitlin. My son Lucas started
Um, we're having trouble with the sound, I see. But that's weird because on this side, it looks like it's good. Oh, that would be such a total bummer if this is not working now. All right, let me see if there's something else I can do really quick. Sorry about this. We had it tested and it was working earlier. And I don't know why it would not be working right now. Well, that is a total bummer. I really apologize for that. We will look and see if we can actually send these videos out afterwards, because I do find that they are really important, and I do want you guys to have the information from them. But obviously it's not beneficial if the sound isn't coming through for you guys right now. So ultimately, what I'd like to summarize from what this mom is saying is that she recognized from an early age that Luca was having struggles. Every year from the time that he was 1, she was going to the pediatrician. She would be asked, how's eating going? And she would continually say, challenging, not great. He really isn't eating very much, and was continually told, don't worry about it. That's normal. He's going to grow out of it. Don't stress. When he was about 4, they did try a outpatient feeding therapy program where he was kind of doing some of that food play and engagement with food. We weren't seeing much success, and so they stopped that program. Continued to go to the pediatrician. The pediatrician told him, don't worry, when he starts school, he will see all of his friends eating and he will start eating. And that didn't happen. And ultimately, over the years, he got down to surviving off of a chocolate Ordein shake. And he was really struggling. He was avoiding going to birthday parties. He was avoiding any sort of like family dinner. He would run away. He was not really wanting to be involved or participate in any sort of activity that involved food. And he was quickly going down in his weight. And so, that was really a struggle for this mom. And, it was sharing this story with her that she struggled for about 5 years, really advocating for this child and trying to get help, and continually being told that he was going to grow out of it. So luckily, she did end up in a feeding program, and for Mr. Luca, he is doing great. He completed the program. He absolutely loves food. He loves eating. He asks for new foods all the time, and just wants to try all sorts of new flavors. And his big kind of motivator for him, what he was working towards through completing the feeding program, was that he wanted to see the Statue of Liberty live and in person. And so he got the opportunity to do that um, at the completion of his feeding program. So there are thousands of stories like Luca's. ARFID actually affects an estimated of 5% of adolescents. So, for our stats for the US, that's over 2 million kids alone. So it's really something important. It's something I want, you guys as pediatric providers to really have your antennas up for and be looking out for some of these families so that we can avoid some of these continued struggles that these families are having. They often will share, I pop into different social media type groups to be able to see what people are saying and where they are struggling. And oftentimes, while these people are going to their pediatricians and asking for this help, is that the pediatricians are not necessarily sure what to do, brush it off as picky eating, offer some supplements, but aren't really getting to the root struggle of where this kiddo could benefit from some help. So if left untreated, right, if we continue to allow kiddos to just eat the way that they're eating, and we don't intervene, it can have significant impact on their health. We see a lot of these sorts of things with our kids as they continue to get older. Oftentimes when they're struggling when they're younger, these things aren't initially highlighted. It takes years of having the food refusal and getting to that point of malnourishment, where you really start to see some of those vitamin and mineral deficiencies, some of the impact on other organs, GI issues, things like that. It can also really impact our development, the child's development. One of the things that often gets noticed that I see in my practice a lot is that we actually use the same muscles in our mouth to chew food that we do to talk and say letters and words, right? So when I see a child that's struggling to move through their textures and transition from a bottle or transition from baby food to regular textured food, is that a lot of times they're also paired with a speech delay. And that's usually because those muscles aren't working in the way that they need to be for either one of those skills. And so it's really something that often is a trigger for me that I will see when I see a child that's struggling with their speech, is that I'm going to look at what that tongue movement and jaw movement looks like. And then this psychosocial well-being. So the amount of parents that I see over the years that really themselves get beaten down as their child's not eating. As a society, we are immersed with food. We are around food a lot of events, a lot of activities, a lot of daily life surrounds food. And so when you have a child that isn't eating, that causes issue around mealtime, that has a lot of built up anxiety and angst leading up to that mealtime or during or after that mealtime, is that can really take a toll on the parents. It can have an impact on siblings, and it's also going to have a direct impact on that child. So we were talking about Luca's situation earlier. He didn't want to go to birthday parties. He didn't want to sit at the family table. He didn't want to be a part of those events that involved food. So a question that I got a lot during registration was, how do we recognize if there's a bigger problem? So these are red flags that really would have you wanting to dig a little bit deeper to see if there might be something going on with this kiddo. The first one's obviously going to be an extremely limited food variety, but also looking at really strong in the way of brand specific preferences. So one of the things that comes up a lot is that a child, let's say, has a solid handful of things that they're consistently eating, and they're getting in some good protein and dairy, and fruit from those items that they're eating. However, they're really brand specific. And so as soon as the yogurt that they might be eating changes their packaging, or the dino nuggets slightly change their recipe, all of a sudden that food that that child was eating is now out the window because it wasn't yogurt that they were eating. They were eating the very particular bluey yogurt in the orange package, right? And so now that food is immediately cut out. And so we really want to make sure that even when you're talking with your families and it seems like they have a decent amount of foods that they're eating, is that if they're really particular about the brand, the presentation of that food, is that that's something that's going to be a red flag for a feeding challenge. Reliance on supplements or nutrient drinks. So if a child is primarily surviving on something like a Pediasure or a Boost, something like that, and or actually a tube, right? And it's not specifically for a medical physical reason that they need that. That's going to be an area of concern because again, it's not something we want them doing long term. If their feeding challenges are affecting their daily life and functioning, right? So if they're not going to the birthday party, if they're not eating at school lunch, those are going to be other red flags. Eliminating one or more full food groups. So if the mom says, he doesn't eat any proteins or he doesn't eat any fruits or vegetables, that's going to be another thing that you want to be able to address with them or work on. This is going to be, the next one's a theme that we're going to hit on a few times throughout this presentation: weight loss, weight gain, or no change in weight. So one of the other components of ARFID is that weight is not a required criteria for the diagnosis. And I want to scream that from the rooftops, that we're going to talk about it a few times here, but if you take nothing else away from this presentation, I want you to hear that weight is not a required criteria for diagnosing ARFID. So while there are certainly some kids who have weight loss due to their lack of eating, or some of them actually are overweight because the only things that they are eating are really high fat and calorie foods, we have some children that for whatever reason are able to grow without much food intake at all. And unfortunately, that's the category of kids that are often getting pushed to the side and continue to be told, don't worry about it because they're growing fine. And those are the ones that aren't getting the treatment until much, much later because their weight wasn't an issue. Intense anxiety, fear, or distress around eating. Obviously, you start talking about foods and the kid coils in, or the mom starts to, have some angst when you're talking about that. That's going to be a red flag. Sudden food refusal after a choking or vomiting episode. So we've certainly seen kids where they were pretty typical eaters, they had a traumatic event, and now their food intake has significantly cut off. We would expect that, right, for a short period of time. But if that was something that was continuing, we're going to talk about some tips later on things that you can do, but one of them is going to be looking at scheduling a follow-up appointment to be able to recheck and assess if that child's eating has returned back to baseline, and if not, talking about what those next steps are going to look like. And that parent reaction when you're talking about food intake. If you ask, how's eating going? And the parent just goes, right? Or laughs in an awkward and uncomfortable laugh, right? That's going to start to tell you that there's a bigger issue at home. So I told you this was going to be a theme. We're going to keep talking about it, right? Growth isn't the full picture. So while children may appear to grow normally, they absolutely can still be at risk. They can be surviving on just a couple of foods and continuing to grow in both height and weight. We looked at a study recently where only 11% of the teens that were looked at with possible ARFID were actually underweight. So most of the ARFID diagnosis kiddos are actually normal weight or even potentially overweight based on the foods that they're eating and what their body and metabolism is actually doing, but it is not a required diagnostic criteria. So One of the things that I see a lot in the field, in my practice, in talking with other parents and people that are struggling with feeding challenges, um, is that their go-to is some sort of supplementation, right? We've all seen the Pediasure commercials where they say, child's not eating, don't worry about that, give them a shake, right? And while I can be on board with something like a Pediasure or a Boost in a very short term regimented plan, right? For looking at uh, how to make sure that we can get back up to a baseline weight. Maybe there's a transition period and we just want to be able to make sure that we're not losing weight. We had a premature kiddo. We want to make sure that they're continuing to maintain, but it absolutely is not going to address the problem for a child that actually has a feeding disorder, right? And so when we rely on it too long, or parents are relying on it too long, is that it actually becomes detrimental to that child. And so we want to really look at these as short-term interval solutions, really not long-term at all. Also, when we think about these shakes and things that we're giving to these kiddos, um, the ingredients are not all that great, right? We've got, this is just one example of one of the boost drinks, but 15 grams of added sugar, right? And a lot of oils and extra sugars, all sorts of things that are inside there. And the first ingredient is water, right? And so when we look at being able to give our child solid nutrients to be able to have them grow appropriately, this is certainly not it for that long-term solution. But we also want to think about it from a social aspect, because we want to make sure that these kids are able to experience those situations like going to the birthday party, eating at school lunch, enjoying family dinners or holiday dinners or those sorts of things. And when we continue to rely on the shakes rather than addressing that food refusal, we're doing only a detriment to that child. So oftentimes what happens is when you have a child that's been restricted for so long, and they do start to lose weight, parents are stressed, child is miserable, uh, they often go that route of a tube. And again, while there are certainly some kids from a medical necessity standpoint that require a tube because for some reason or another they cannot orally eat, if we're talking about behavioral refusal for feeding, is that it absolutely is something that can be worked on. And by putting in a tube, we're really just avoiding the continued problem. And we're actually making it more difficult for that child to be able to regain eating in the future. So, I kind of made just like a mock timeline of what is currently happening when we see kiddos that may have feeding challenges. The little toddler, 2 years old, they're having that limited diet. They're not seeing any changes or issues with their growth. And so often they are recommended to just wait it out. It's picky eating. Again, we're going through this toddler phase, and it's not something that we need to necessarily address. As that child continues to grow, now they're 3, now they're starting to have tantrums at meal times, now they're starting to have some trouble sleeping. Things are starting to get worse, right? They're only now eating 4 foods. And so now the pediatrician or, provider that the family is seeing may start to say, hey, you might want to try a feeding therapy program. And often the first type of feeding therapy program that a child is going to find is going to be one where they're doing more of that interaction and play with food. And unfortunately, it doesn't always lead to consumption for kiddos with severe behavioral feeding challenges. And so what happens is that those feeding challenges are continuing to persist with emerging concerns around sleep and behavior and now GI issues, right? And things are getting more intense for that child, because just like us as adults, children get hangry, right? We all have that feeling of if we're not getting in enough food during our day, we get to a point where we're pretty cranky and we're pretty miserable. And the same thing's happening with these children. And so the longer that they go and the more time that they go without getting in these nutrients, the more crabby they're going to start feeling. And so you're going to see these behaviors escalate. And so usually it's not until those later school years where they may be finding some other options for feeding therapy, ones that are focusing more on consumption, on actual act of eating those foods, where they're starting to see those changes in success for that child. So my hope, right, as future of addressing feeding concerns is that we can start to identify this a little bit earlier and help both the child and their family around them to not have to go through the years of stress that a lot of them end up going through right now. So ideally looking at that kiddo again, he's 2 years old, parent shares at an appointment that he has a limited diet. It's increasing her stress on a daily basis, but that child is growing. But now, as pediatricians and nurse practitioners, right, you're going to be going through some of these screening questions that we're going to share. You're seeing multiple red flags that are identified, and you're able to talk to your parents about effective feeding programs, right? Looking at programs that are having goals based on actual eating consumption. And so that child can actually start eating a wider diet so that when they're 3 or 4, right, is that they've completed that feeding program, the parents are feeling more confident about mealtime, and that child doesn't get to that point of significant hangriness and escalation of sleep troubles. We don't see those issues with toileting, and often they're able to have a much more positive experience and social interaction with food. All right, so we're going to get into our another case. And, again, this will be another one. We will figure out how to send these videos to you so that you can hear them. This girl is Ella. She is 12 years old, or was 12 years old. She had a diagnosis of anxiety and emetophobia. She was afraid of vomiting. And she also got diagnosed with ARFID, but she went into heart failure due to her malnutrition. She ended up in a hospital setting. She was put on a tube because she was presented with food and she wouldn't eat it. And she, was pumped in with calories through the food to be able to build up her weight. She was down to, I believe, 62 pounds at 12 years old in that hospital program. So Ella's mom definitely explains this whole situation. And again, we'll share that story. But she obviously went even more years with these struggles to the point that Ella's, got really severe to that point of that inpatient hospitalization and really required some more intensive care. Good news, however, for Ella, is that while she was on the tube, again, that was used for a short-term get her out of the danger zone and then focus on how to fade off of that tube. And so she was only on the tube for about 3 months, and she has now been off for over 2 years. And she eats food, she makes her own food, she's cooking for herself. She had so much anxiety that she reverted to a cyber school so that she wasn't in school. She didn't really have the stamina to make it through the day. She didn't really want to sit at lunch. She was avoiding hanging out with her friends. She now started back school in person this year. She's feeling better. She's growing. She was able to finally hit puberty. She had enough calories in her to be successful with all of those things. So this is one of those examples where the tube was really necessary. She was in a severe danger zone medically, and it was utilized for that short interval of time to be able to get her to safety and then be able to look at how can we get her back to that oral eating. It wasn't, a sentence for the rest of her life that she was going to have to be on that tube. So I hit on this earlier when we were talking about the diagnosis, but I felt it important to bring it back again. Um, we don't want to group children with ARFID as the same as kids with anorexia and bulimia. So oftentimes what happens in a lot of programs is that they are culminated in an eating disorder program. So they will take anorexia, bulimia, or ARFID because ARFID falls in the technical diagnostic criteria as an eating disorder. But it really is its own diagnosis and requires a different treatment for that long-term success. Again, ARFID is not focused on body image, where anorexia and bulimia are, meaning those root causes as to why we're seeing that food refusal is different. And so we want to make sure that we're having a different intervention. So when we think about what those interventions are and what we can look at for ARFID and pediatric feeding disorder, food play, right, and more of those exposure-based approaches I was talking about earlier are often emphasized. They're usually the ones that you see first, hear of most commonly. Uh, but the evidence consistently supports interventions that are directly targeting consumption, the actual act of eating, rather than playing or getting more comfortable with the food. So those eating and food consumption programs are often rooted in applied behavior analysis using systematic and data-driven strategies to help these children expand their diets. We're really looking at, you've got a child that's not eating. We want them to eat. We need them to eat, right? So that they can actually get those nutrients inside their body. If we're spending an excessive amount of time in the play and interaction with food, and it's not leading to actual consumption of food, it's not going to necessarily be looked at as an effective therapy for feeding, right? It may be helpful in a sensory integration approach and, being able to get them more comfortable with the different textures and smells and tastes, right? But it's really not always leading for most kids to that actual food consumption. An example that I would love to share, that I share often, is thinking about a raspberry, right? If we think about a raspberry, I don't know if you like eating raspberries. I love to eat raspberries. I can pop them in all the time. But if I really look closely at a raspberry and start to notice the little hairs that blow off of the side of it, how it's bumpy and smooth at different parts, and parts of it are shiny and parts of it might be squishy. And now I've really exposed myself to a variety of characteristics of this raspberry, and it's making me less interested in actually eating it. I might enjoy playing with it, pulling it apart, squishing it, but it's not going to make me want to now put it inside my mouth. And so we really want to focus on a feeding therapy program for that actual reinforcement of consumption. However, there's major benefit to a multidisciplinary approach, right? So for severe behavioral feeding disorders, ABA therapy is the only empirically validated treatment. But that doesn't mean that we don't often collaborate with other specialties to make sure that we have well-rounded care. So first and foremost, we're looking at those medical providers, right? When we talk about feeding the challenge is we always want to make sure that we are first ruling out any medical complications, or at least becoming aware of them. So if they're not directly going to impact the child's ability to eat, right? But it might be impacting the types of foods that they can eat, how much food they can eat, right? We're going to be able to make sure that we're pulling in that child's medical team to get those pieces of information. We also would look a lot at speech language pathologists when it comes to feeding, right? Speech language pathologists have a lot of training in oral motor skills and the movements of the jaw and the tongue and the mouth and all of those things that are involved in eating. We don't actually realize the amount of work that our mouth is required to do in order to consume food. And so if it's not really working effectively, we want to make sure that we can build up those skills so that we can introduce those more regular textured foods. And so working closely, if you have a child that's struggling to manipulate food inside their mouth with that speech pathologist, is going to be really helpful. Occupational therapists, oftentimes my collaboration with them comes with things like core strength. So one of the things we see a lot is kiddos that are struggling to sit up, and so they're hunched over. That's not going to be effective towards great mealtime. We want that child to be sitting up straight, gripping that spoon or fork and scooping or stabbing effectively and bringing that food from the plate or bowl up to their mouth. And all of those things are great skills that occupational therapists can work on the child in regards to those corollary feeding behaviors. And that BCBA, the board certified behavior analyst, that would be specifically trained in feeding. So there are certainly BCBAs that are not trained in feeding. And oftentimes I do not recommend that they are doing any sort of feeding intervention, but ones that are going to be able to work with that child on that actual food consumption once all of those other areas have been addressed. So many professionals who are unfamiliar with behavior-based intervention for feeding therapy present concerns surrounding personal choice. This is another one that comes up often. I think a few people have asked about that. They were talking about, why are we requiring a child to eat? Where is that line? Is this fair? Is this not fair? I want to share an example with you and see, where you guys fall in some of this, right? So most of you, I'm guessing, are pediatricians or nurse practitioners in some sort of primary care pediatric setting, right? And if you had a parent come in and you were doing an evaluation with them, asking them all of their questions for their well check, one of the common ones that we get a lot, right, or that you would provide a lot, would be, is that child in a car seat? Or are they buckled safely, right, based on the age of that child? And if you had a parent that said, no, I mean, I know that they're supposed to, but he really screams and cries every time we try to buckle him in. So I just let him sit on my lap while we drive places, right? And he loves holding the steering wheel with me, and it's so much better. And I'm so much happier and more relaxed. And so is he when we are driving now, because he doesn't have to be restrained and buckled in the car seat in the back seat when he's not with me, right? I'm hoping, right? All of you would be going, what? We can't do that, right? Because there's a safety concern. There's an initial boundary that has to be met, right? Also a law, but take the law out of it, right? Huge safety concern to have your child sitting on the driver's lap while you're going anywhere in the car, right? I want to be able to think about that non-negotiable activity, right? The child was required to be strapped in their car seat while the car is moving. We need to think about what are some of those other types of non-negotiable activities that we would expect from our kiddos, right? So we have that buckling in the car seat, staying out of a busy street, right? You're going to have to hold mom's hand, or you're going to have to go in the stroller if you're not going to be able to, stay out of the road. Needing to take medication, needing to put on sunscreen, right? We have all of these kind of non-negotiable boundaries that we set as both providers that we're looking at with the families that we see, and as parents, right? Consuming nutrition needs to be on that list. And there has to be a baseline set, a boundary set for food consumption that then can certainly grow, right? Certain kids are going to be great eaters. Other kids aren't going to necessarily be the most amazing eaters, but we need to have a baseline of expectation to not only grow in both height and weight, right, which is important, but to make sure that we're getting in the right nutrients, to make sure that our bodies are feeling satiated and full, and so that we're able to concentrate and function throughout the day. We always want to make sure that within any feeding therapy program that we build in the food choices, right? I say kids won't like every food. No person likes every food. And that's the case across the board. I have not met anybody that will say, I will eat anything no matter what, right? Everybody has preferences. But what we look at from a feeding therapy standpoint is that we have to be able to find that baseline to establish those preferences. So what do I mean by that? So when I think about my programs, we'll take the categories of fruit, for example, right? There's probably, I don't know, a lot of fruits, probably more than 20, right? We want to be able to look at probably about 3, maybe 4 fruits in which that child can rotate through. You don't need to like them all. You're not going to like them all, but we need to be able to be exposed to them repeatedly over multiple different presentations to establish whether we really like or don't like a food. And or if we're just avoiding it because we've never had it, or we thought it was bad, or we were worried about it, or we had angst about it, right? We need to be able to get over that hump and try some of those bites of food so that we can make more of that educated decision. For some of our kiddos, especially ones with ARFID, they don't necessarily have that same internal drive or interest in eating as we see with other kids, right? So some of our kids, once they start eating, they go, oh my gosh, food is amazing. Like our friend Luca in the earlier slides, he loves food, seeks it out, enjoys it all the time, right? Other kids, we want to be able to at least get their oral intake to a safety baseline level. But they're not going to have that same interest in food. And so with a lot of those kids, I'm looking at more of how easy or hard is that food for you to eat versus whether or not you really love that food or not, because they may not necessarily have any love for any food. But as humans, we need to make sure that we're getting in some of that consumption to be able to survive. So what are those benefits of successful feeding therapy, right? If we get into an effective feeding program that is working well for that child and that family, you are going to see with that child improvements in sleep at night. When our body is fed, our body can sleep. Regulating emotion during the day, we get rid of the hangriness, right? And we're a little more able to work through the different tasks that we're presented with. You're able to sustain energy longer. Articulating vocal words, right? We talked about that with the muscles in our mouth, right? And being able to, we're starting to use them for chewing. You're going to start seeing that they can actually get easier to pronounce those words that you've been waiting to hear. Toileting regularity, the amount of kiddos that struggle with constipation directly correlated to their diet is huge, even more so in the autism community. We see that a lot. But if we can get more of a consistent oral intake in, that's one of the first things parents point out to me is, holy cow, this kid can poop once they start actually eating those foods. And so we want to make sure that, we're getting some good toileting regularity and engaging in those social interactions. We want to be able to have those kids feel comfortable getting a piece of pizza at the birthday party, going to eat something at their school lunch, or being a part of a family dinner. What can you as providers do? This gets to the nitty gritty, right? Where people start to say, well, what am I going to be able to do? So there's a few things that we can look at, right? First and foremost is going to be asking the right questions. And one of the things we'll get to at the end of this presentation is that we're going to send you a whole resource book that's going to get into those red flags and some very specific screener questions that you can use in your practice to be able to help highlight if a family is experiencing those red flags. So we're looking at, are they eating some foods from each of their food groups? Are they limited in the amount of foods that they're eating? Is mealtime stressful? Have you seen a sudden drop in oral intake, right? Those are things that we want to be able to look at. So we want to ask more of those specific questions rather than just, are they eating, right? Because some kids might be, but they may still have some of those red flags. The other thing that I encourage you all as pediatric providers to think about is listening and validating those parents. So rather than just if a parent is coming in stressed about food and saying, "Ah, don't worry about it, they are growing fine, they are gaining weight, look at them on that growth curve, don't stress about mealtime." Um, they're still stressing about mealtime. And so you want to be able to allow them to know that their concerns are valid, look a little bit closer, maybe ask some more of those screener questions, and acknowledge how exhausting meal times can be. So even if they are growing, so they're not in a severe or immediate danger, is that there's things that we want to work on so it doesn't get to that point. Considering top barriers to access to feeding therapy, right? Biggest one across the board was everybody ask me after every presentation that I do you take insurance, right? Or do you know the providers that take insurance? Because that's one that comes up all the time. So we have to be able to look at the providers in your area that are doing feeding therapy. Are they taking insurance? Is in choosing a provider just based on whether or not they take insurance the best way to go about it? Are there other resources or things that you can look at? Looking into the long wait times. A lot of our bigger hospital programs that are running feeding therapy programs could be out on a 2-year wait list. So even if the family's on that list, we don't want them struggling for another couple years. So we want to be able to look at some other options. And then we want to look at creating a plan based on the severity that the family is describing to you. You want to make sure that you're really trying to avoid defaulting just to Pediasure, unless again, it is medically necessary for that short term, that child's really losing some weight. We want to be able to get some good nutrients in while we're waiting for that feeding therapy program. Looking at potentially scheduling a follow-up visit, even if it's a well check, even if things otherwise look well, if they're talking and very stressed about mealtime, do a check-in in a couple months. One of the other resources that we're going to share with you is a food log that you can share with the family so they can actually start tracking what that child is eating every day. And that can be something that you can look at. You can maybe connect with a nutritionist on your team or, in your area. And so now I want to be able to get into with you guys some of the things that you can start with to share with families, some initial suggestions for ways to increase that food volume and variety, and being able to see if the child is responsive to them before they would start any intervention. So first and foremost is looking at only offering food at designated eating times. So really structuring the times in which that child has access to food during the day. What happens a lot of times, especially with kiddos that fall in that significant picky eater or getting into potential feeding disorder, maybe not diagnosed yet, they're not eating well, is that any time that they request food is that a parent is saying, yes, okay, yes, okay. But what happens is then they're leading to just kind of snacking throughout the day, and not really getting the opportunity, one, to feel hunger, right, and go through the cycle that our body needs for appropriate digestion. And it's also going to make it a little bit more difficult to actually have them want to sit down when it's time for a family meal if they had just been snacking. And so when I start this recommendation with any family, I say, you're not changing anything about the foods that the child eats. So this is if the child is only eating Doritos, hopefully not, but if they were only eating Doritos, you would still look at doing this with the Doritos. You're not looking at introducing new foods yet. You're just looking to start teaching how we're going to actually eat. So we want to make sure that they have those eating times, that they're coming to a table and sitting at the chair to be able to eat. And that, when they're done, they can get up, they can run away and play, and then they can come back to eat when it is that next meal time or snack time. And the benefit of that schedule, besides the things we just talked about, is also that it allows for some structured snack times that have intervals before or after a big meal, in which we can start the introductions of new foods when we think about, getting them involved in an intervention program, is it will allow for that opportunity to start some new food practice outside of a bigger mealtime. Encouraging flexibility by varying food forms and presentations. We talked about this with the brand's specificity earlier as being one of those red flags. Really encouraging families early on to be able to change up, whether it's the shape of the chicken nugget, whether it's the color of the outside of the yogurt, whether it's the flavor of the yogurt, being able to make some small little adjustments, going from a goldfish to a Cheez-It, right? Being able to do some little things that it can allow for some continued flexibility and generalization for that child and the foods that they are already eating. Avoiding engagement with foods outside of consumption. So avoiding that food play, it really starts to send some mixed messages. Sometimes I come to the table and I get to play with all of my food and squish it, and I don't have to necessarily do anything with it. And there's other times where I come to the table and the food is there and I'm supposed to actually take bites of that food. And so that can be really confusing for some kids, and also sometimes make that eating aversive if they have those heightened sensory sensitivities to the food. So I always encourage families and providers to encourage their families to find things to play with that aren't directly food, and make sure that they're not, playing with food, squishing food, throwing food across the room. We want to be able to set up what those boundaries and expectations are for mealtime. And then also looking at, is there something else that you can work on around mealtime that isn't directly food related, right? So if we have a child that's struggling with being able to sit at the table, then perhaps, working on building up a little bit of stamina for that, right? Obviously age dependent. We wouldn't have, a little 2 or 3-year-old sitting at the table for a really long period of time. But we certainly can build that up small so that they can start to get comfortable with coming and sitting at the table. Looking at grip strength for those self-feeding skills, fork or spoon, again, in that scoop and stab and that hand-eye coordination, bringing it up to their mouth. And or achieving completion of another challenging or non-preferred task, especially with those school-aged children. So we want to be able to find what is a motivating factor for them? What is something that is going to be able to help them succeed in something else that's hard? And can we apply that then to feeding? And so those are some things that you can suggest to families kind of in that short term when they're going, what can I do? Right? Give me an idea of something to try, right? These are things to try that you can either be able to get some success and build off of that, or be able to say that we're not having success with these interventions, and now we really need to look for a more, professional intervention strategy. So as I mentioned, we put an entire book together that we are sending to everybody that registered for this presentation today. Again, this is part of the grant that we were provided. So we will be sending this out to everybody. It has a lot of background information on ARFID and pediatric feeding disorders. It talks about feeding interventions. And then it also goes into some tools and references for you to share with the families that you are seeing. I hope that this was educational and helpful for you guys today. I really appreciate you attending, and please do not hesitate. This is my direct email. Reach out to me through email or connect with me outside of this, and I would be happy to talk with you more, answer any other further questions that you have. Alrighty, I hope everybody has a great rest of your day. Bye.